So I can see that we have gone live, and just welcome everybody who's already logged in. We'll just wait a couple of minutes before we kick off, and I'll introduce our two speakers. Okay, well, I can see that we've got close to 170 participants, and it's just in the middle of past the forenoon. So let's begin. Welcome everybody to this seminar on how COVID-19 is impacting healthcare workers. My name is Richard Newton. I'm the Clinical Director of Psychiatry here at Peninsula Health, and it's a great pleasure to be chairing this meeting. Before we start, I'd just like to acknowledge the traditional custodians of the various lands on which we work today, and the Aboriginal and Torres Strait Islander people participating in this session, and pay my respects to the elders past, present and future. Cameras and microphones have been turned off for everybody at the moment. If you wish to ask a question of the panel, use the Q&A function. By clicking the icon on the toolbar on your screen and the Q&A function, and I can see some people are already using it. This session is being recorded currently, and when people are not speaking and not participating, then cameras and microphones will continue to be turned off. Now, I'll just introduce the session a little bit. We all are aware and are all experiencing the ongoing stress of living with this COVID-19 pandemic. We are all members of our community, and on top of that, we are all members of the Peninsula Health Service and have been working for more than 6 months now, responding to the ongoing, really extraordinary stresses of trying to deal with both the health service response to this pandemic as well as our own personal and community responses. More recently, we have had our own outbreak of COVID-19 at Peninsula Health, which impacted markedly on people who had COVID-19 here, and impacted on all of us with really a remarkable change in the amount of work that we were all doing, the rosters that people were being asked to work to in order to maintain healthcare for our community. We all had to manage one way or another with the publicity around the outbreak here, the impact of being questioned and concerns being raised by our family, our friends and broader community that we live in, work in whilst also working in a service that was under some media scrutiny as well as under great stress as we try to cope. And so Kim Jenkins and Brett McDermott, who are currently providing seminars on helping people understand and respond to the COVID-19 pandemic across healthcare services, have kindly agreed to present today. Kim, some of you will know, she is a recent past president of the College of Psychiatrists, and so El Presidente. Once a president, always a president, you know how it goes. But also Kim has for many years been an extraordinary leader in providing the Victorian Doctors Healthcare Program Service, VDHP, which some doctors here may have accessed and will, I am sure, have found it a useful, compassionate and supportive way of accessing support in healthcare when in difficulties. So it's a great pleasure to have Kim here. And at the same time, we have Brett McDermott, who is an academic child and adolescent psychiatrist, trained in the UK, so obviously excellent training behind him, as well as working at JCU at Townsville at the moment as the Professor of Psychiatry there. He is a By Fellow at Cambridge University and has a number of academic roles in Queensland, as well, of course, as providing input into the college. They're going to be talking, Brett will present first on some of the academic lessons from disasters before Kim will speak around burnout and how to foster well-being during difficult times. So it's a great pleasure to have you both here. Thank you very much for coming. Thanks to Amanda Armstrong and Jess Mills for organising this. And I'll hand over to Brett to kick us off.
Thanks very much, Richard. And it's an absolute delight to be here. And we rather hope that what you're going to hear is helpful. Now, Richard, if you could just indicate, are you seeing a PowerPoint with a pre-COVID me on it?
Yes, but you need to put it onto PowerPoint slideshow. At the moment, we're seeing the whole of your desktop.
Yeah, the problem with that is that I'm on a split screen.
And now we no longer have your slideshow at all.
How about that?
Perfect.
Okay. So curiously, I've been in a fairly rare field of research, disaster research, and it's a very unsexy area of research until you get an international pandemic, and then people are kind of fascinated about what we can learn from disasters. So, and I'm in disaster research mainly because I live in Queensland, which does a good disaster. So in academia, there's always slides or graphs that you wish that you had published. So we all wish we'd published this. It's actually what happens in the typical time course of a natural disaster. And I'll tell you about this, and then I'll tell you what I think, how we can apply this to COVID. So in a natural disaster, you always have this pre-disaster phase. And everyone in Victoria knows this. It's, for bushfires, it's hot, it's dry, there might be, a fire somewhere. In Queensland, we all watch bomb radar and we see these cyclones coming towards us for days. So there's a pre-disaster phase. And of course, in COVID, the pre-disaster phase was watching Wuhan, but then really watching Italy and Spain. We all knew that this could come. Then there's impact, and then there's this kind of heroic phase where, people do amazing things and people pull together. There's huge social cohesiveness. People work, 26 hours a day. They go beyond what's expected of them, and they do heroic things. And you see heroic things in bushfires and floods, but we've also seen that in the Victorian health system. People have been, going above and beyond, but also outside of health, there's a lot of social cohesion around this. It's kind of like, some people describe it as the honeymoon phase. Now, it might be something natural about human behavior, but we can't maintain this forever. And there's always a phase of disillusionment. Now, after a natural disaster, that's when the disaster is over and the first responders all start to leave, and you're left in a paddock with a burnt house, or you're left in a small town with a cyclone ravaged kind of reality, and you're left. It's called the phase of disillusionment. In Australia, this is always in winter, because kind of weirdly, all Australian natural disasters are pretty well in summer school holidays. Bushfires down south and cyclones and floods up north. In the middle of the year, people get especially kind of disillusioned because the media often focuses on something else and they feel forgotten and missed out, and people feel that their experience is now not at the front of anyone's mind. Then there's a long period of recovery with ups and downs, and a down is anniversary reactions, which often makes people feel worse. And you can have a down when you're trying to get money out of your financial institution to rebuild, and you can have an up when things are going well. But what we know about recovery is it's every time someone publishes a paper on recovery, it kind of gets longer. And now we know that it's a minimum kind of 3 years post a natural disaster. We know a lot about the mental health of natural disasters, and in Australia has been a significant leader on this. There's lots of papers from Australia. In the acute phase, or an acute event, you can get post-traumatic stress disorder or panic. GAD is generalized anxiety disorder, or you can get depression and a grief response. Now, it kind of depends what you experienced. If you experience threat, and overwhelmingly the most important question after a disaster is did you think you were going to die? If you answer yes, you thought you were going to die, your chances of PTSD increase from 5 to 10-fold. So 5 times to 10 times more likely. Now, with COVID, there will be people who thought they were going to die. By the way, both patients in intensive care, but also healthcare workers who maybe not so much in Australia, but certainly in parts of the world where there's been a lot of death in healthcare, people would be worried about thinking they might die and will get PTSD. So there's a threat pathway. There's also a loss pathway. If you've lost loved ones, if you've lost possessions, if you've lost your whole meaning for life, you can go down a depression or grief pathway. Now, by the way, I've put down chronic events. There's actually a chronic disaster. People think disasters are kind of acute, but Australians all know about chronic disasters. And the example here is the 7-year drought. It was ongoing, it was relentless, it rolled on, and people got increasingly levels of hopelessness and helplessness. People lived on the land with no rain for 7 years. There's a bunch of kids who had never seen rain. And we know, and I was on the Beyond Blue board when this was happening, and there was a stage in Australian history where a farmer was killing themselves every 4 to 5 days in Australia. So depression, hopelessness, suicide are around chronic events, but also things like relationship breakdown, domestic violence, increased substance abuse, especially alcohol. Now, just a little extra here, neuropsychiatric, neurological things, we actually don't know about how they fit in a disaster model. Obviously, they're year 2, year 3, but I would like to point out that, COVID's a lot more than the threat of death. We know a lot of people after normal flu seasons, well, there is an instance of chronic fatigue syndrome. After Spanish flu, there was a major uptick of Parkinson's, and people with Parkinson's are more likely to get depression. There's already increased notification in case reports. There's a case series in the Lancet recently with increased psychosis, mainly for those who have experienced kind of intensive care and hospitalization, people with serious illness. Now, what's going to happen with us? Well, we have all those first phases. I think a lot of us are terribly into disillusionment at the moment. I think the honeymoon is well and truly over, and disillusionment has a lot of those negative affects like anger, you know, feeling low, feeling depressed, feeling anxious, feeling angry. They're natural things in this phase. Now, I've put a blue line and a red line in the recovery phase. Now, we have some knowledge from the global financial crisis. Now, the global financial crisis really didn't hit Australia in that we never went into recession, but it was so profound in some countries. It's called the Great Recession. So in Spain and parts of America, they actually call it the Great Recession. Youth unemployment went to 28% in Spain. You know, there was a while in Brisbane where the only people that served me coffee had Spanish accents because the youth of Spain had to leave to get a job. Now, there is really good research. It's now, you know, 10 years old. The GFC was 2009, that shows that there is a significant increase in suicide after the GFC, mitigated by what your government did about investing in job creation and job maintenance. So the blue line's the, one outcome where you have a quicker recovery, and that's where countries invest, especially in youth, but in everybody, especially, you know, invest in the economy. And the red line is much worse, and where you don't invest at all. So things like JobKeeper, Job Seeker are actually mental health interventions as well. Now, Kim's going to talk more about this, but I just want to point out in kind of my last 3 minutes, and we can talk more about this in questions, is that prior to COVID and prior to all this knowledge about disasters, the medical nursing profession was actually not doing particularly well anyway. And there's now research on professional quality of life, compassion, satisfaction, compassion, fatigue, and burnout. And I won't give you some definitions. We'll just go to some cognizance here from, this is the Beyond Blue study of 11,000 Australian doctors and medical students, mainly doctors, 9,000 doctors. And this has been replicated in a Victorian study of nurses. And you can see, I've put the confidence of intervals there, you can see that male and female medical practitioners have statistically higher rates of psychological distress than the Australian population, and way higher, 10 times higher than other professions. I just have to turn on my stopwatch again. Come on, stopwatch. In terms of burnout, these are some of the things that make up burnout: emotional exhaustion, cynicism, and a low sense of efficacy. Again, pre-COVID, you can see more so in our younger doctors, but in all doctors kind of really, about 35 to 40% feel emotionally exhausted. High rates of cynicism, which is related to burnout. And, about 12 to 15% feel a low sense of professional efficacy, which is related to burnout as well. And weirdly, we published a study with Chinese doctors earlier this year, this is pre-COVID, showing that depression and anxiety is highly co-occurrent with burnout and secondary traumatic stress. Now, there is some good news, and the good news is there's been support around the world for healthcare, and there is some mitigation. Wuhan they claim had 42,000 health workers appeared to join the frontline workforce in Wuhan, and there's been clearly strong public support in Italy, Spain, the NHS, and some parts of the USA. So just to summarise my quick segment, and we can talk about this more, we know a lot about natural disasters. We know a lot about the natural history of natural disasters, and COVID, I think emotionally follows a lot of these issues. There will be emotional issues now, but the big problem for what we will experience is, in a mental health sense, is pushing that over the next 2 or 3 years in terms of anxiety, depression, and the potential of suicide, and also things like burnout in the health profession. So thank you, and over to Kim.
So thank you very much, Professor McDermott, Brett. Could I just ask people to use the question and answer function to post their questions, and we will have at least 20 minutes to have a conversation about some of these important issues around health of healthcare workers during disasters. Kim, thank you ever so much for coming. I'll hand over to you. I think I've already introduced you.
That's okay. Hoping everybody can hear me okay now. And Brett is going to be advancing my slides because my computer's gone to be repaired yesterday, which was really good timing. It's good to be back in the peninsula, even if it is only virtually, because I used to work down in Rosebud a couple of lifetimes ago, it feels like now. My talk's going to be very different. It's going to be based on clinical experience. I've really drawn on conversations I've had with patients who are healthcare workers who've seen me and come for help during the time of the pandemic and things. So bit of a different slant to this, lots of pictures and lots of things to think about, I hope. And as Brett indicated, you know, there's like a whole range of feelings and emotions that we've all been going through, some more than most, during the pandemic. And it's a bit like a roller coaster that you can't get off at times. And I hate to use the word unprecedented, but I think many people are feeling feelings that and emotions and going through things that we've never experienced before. And, you know, we've all been really concerned about our physical safety, and our psychological safety ought to be just as much of a concern as well. So whole range of feelings of emotions, many of them very unpleasant, but they're not all mental illness. So if I can have the next slide, Brett. This is just a reminder that to all of us that we're all vulnerable at the moment, and our colleagues are vulnerable as well. And though we often use this expression in the pandemic, oh, we're all in this together, everybody's experience is different. And so none of us know what the person next to us is really going through, how fragile they're feeling at that moment in time. But there's also a message in this about just being kind and being considerate of others, because we don't know what anybody's backstory really is at the moment, because we all bring a different range of personal experiences to something like a disaster, and that can impact on how we cope with disasters and things. So next slide, please. What I'm going to do now is just put names to some of the awful feelings that some of us may have been feeling at this time. Obviously, I can't go through every emotion that we've possibly felt during the pandemic, but I've just picked out about 4 of them, and Brett's already mentioned a couple of them. If I have the next slide, which is the one on burnout. Now, there's a lot of literature now on burnout and burnout in people in healthcare. And as Brett said, one of the sort of key symptoms is feeling cynical and doubting things. I just compiled a sort of like top of my head list here about some of the things that I've seen in people who I've sort of diagnosed with burnout in the past few months. It was really interesting, actually, because as a psychiatrist, when you do your psychiatry training, you don't learn much about burnout because it doesn't come up in the DSM-4. But as soon as I started working in Doctors' Health, I thought, this is actually very, very real. And burnout's going to get a bit of a Guernsey in the ICD now, but it's not a mental illness, it's a state. But if you think of a sort of continuum with stress at one end and depression at the other end, burnout somewhere in the middle there. So some of the symptoms that you could experience when you're depressed come out when you're burnt out. Like, you know, you're tired, you're worn out, things feel a bit hopeless. And it can be a bit of a slippery slope into depression. But some of my favorite ones were like dreading to see patients. And I know some of us can feel a bit like that anyway, whether it's burnout or not. but it's a question of knowing yourself and knowing whether that's more than usual. Chronic complaining. It shows my age here, still delaying doing paperwork on the list there, but you know, you're burnt out, it's harder to get round to doing things. And then there's that personal loss of confidence, that doubting yourself professionally and clinically. And I love the one about fantasizing a change of career. Before I went into psychiatry, I worked in general practice, and I know in hindsight, I really was quite burnt out, because I had this fantasy when my kids were small that all I wanted to do was give up medicine and make cushions and become an interior decorator. And reliance on drugs and alcohol to unwind. You know, just checking on yourself about what you're using for your coping strategies. You know, enjoying a drink at the end of the day is very different from needing that drink in order to unwind. So just a few thoughts there on burnout. The next slide. I was going to say a couple of words about moral distress, which in some ways is closely related to burnout. And sometimes when we think we're suffering from burnout, the underlying causes are moral distress. And experiencing a lot of moral distress can actually lead to burnout. And all these concepts I'm talking about are very interrelated. But the moral distress, I think, people have become a lot more aware of it in the time of the pandemic. It's when we find ourselves saying, hey, that's not fair, that's not right, I can't make that decision. We shouldn't actually be having to make that decision. I shouldn't be here enforcing the fact that this family can't go and see their loved ones in hospitals, that they can't be with the people they care about when that person's in palliative care at the end of their life, and what they need most is their loved ones around. So in this concept of moral distress, there's a lot of ethical considerations about fairness and distribution of resources when resources are limited, but also weighing up two things that, you know, both of them are important or vital, but you can't have them coexisting at the same time. And that's caused a lot of stress to people as healthcare practitioners at the moment. Next one. Next slide, please. This is something that I think many of us who've been working in clinical areas or any caring area, or any area where you're asked to give a lot of yourself, where you need to give a lot of yourself, and that's compassion fatigue. Anyone who works in healthcare does it because it's healthcare, because we care. And we're all feeling socially connected with patients and their families. And there's inevitably a bit of emotional engagement there. And we can have quite intense interpersonal relationships with others. But there are times when you go home at the end of the day and you think, I've got nothing left to give. I'm absolutely drained. My supply of compassion that I can give to others is completely worn out. And there's a risk there that you can go on to this state that I've called here an empathy bypass. We can go on to automatic. We're going through the motions in our work because we've used up our supplies of compassion to connect on a meaningful level with other people. This can be a warning sign of burnout, but it's also very distressing for healthcare workers, because most of us, when we leave work, we've got families to go to, and they're going to demand more of us. And we're going to have to find something left to give in order to be a member of our families and contribute there when we get home. Next slide, please. The next one I'm just going to say a couple of words about is trauma. And we've seen and we've heard so much about the direct trauma of the pandemic and COVID. And even if you haven't been at the front line, you can be traumatized by what we've seen on television. And in Brett's diagram at the beginning, he showed that anticipatory anxiety. And I think we were all potentially traumatized by the sights that were coming to us from overseas. And then our own anxiety got worse, expecting those things to happen here in Australia. The other topic, the concept I've got on this slide is vicarious trauma, which is not when we experience things directly ourselves, but when we're with people who have experienced it. And it's because we have empathy, we have connections with other people, we can experience or realize through our own imaginations and by the sympathy we have for others, the stories we hear from patients or the stories we have from colleagues of what they've been through. And when people share horrific images of grief and horror and rage and anger, we can experience vicarious trauma ourselves. And vicarious trauma can affect you whether you're on the front line, so to speak, or whether you're there working with healthcare practitioners and you have empathy for what they've been through and you experience it as well. And if you go through a lot of vicarious trauma, it can actually lead to you feeling very unsafe in the world yourself. And it can challenge your understanding of the world. And sorry for the formatting on this slide, both trauma and vicarious trauma can be overwhelming. But I need to include the fact there that for many people, we go through traumatic experiences and we come out stronger. And there's another really important concept here of post-traumatic growth. Next slide, please. Obviously can't go through all the emotions that it's possible to feel at this time, but I thought I'd talk now a little bit about dealing with those feelings. And what I've tried to do on the last few slides is acknowledge that there is a vocabulary, there is a name. Those sort of experiences, what we could have been feeling, are very real concepts. None of them are mental illness. They're just really unpleasant states of feeling and emotion. But I think if you're going to deal with something, acknowledging that it's there, recognizing it, even putting a name on it helps. And here I've got just a few slides coming up of conversations that I've had with healthcare workers over the past 6 months or so. And I put a warning on this. There's a lot of plagiarism in this, and there are no original ideas or novel concepts in the next few slides. So if I can have the next slide. I'm going to talk about self-compassion. And we like to think of we all know what compassion for other people is, but actually having compassion for yourself. And the first start of it is being kind to yourself. Now, that's not always easy, but without getting too philosophical and quoting the Dalai Lama too much, if you don't love yourself, you can't love others, and you'll not be able to love others. If you've got no compassion for yourself, then you're not able of developing compassion for others. And this was brought home to me by a very compassionate, and I'll tell that story over the next bit. Anyway, so having self-compassion requires being in the moment, being aware of the experiences we're having and being able to sort of evaluate them, not ignoring them and not exaggerating them. If I can have the next slide, please. For many of us in healthcare, role reversal is tough. We spend a long time learning to be caregivers, and it's so hard to shift over to being the care receiver. And the next slide. When I found this, there's a lot of social media in my next few slides. This is the warning. You're going to have good days, you're going to have bad days, you're going to have overwhelming days, and days when you're too tired, and you have days when you think I'm great, and your days when you think I can't go on, but you still show up. And I think a lot of us can identify with this during the time of COVID. We are feeling that we have to keep going, and we feel good. We feel quite heroic that we still get there. But I thought, actually, even though this looked like it was a very positive message coming through here, it's not one that we need at the moment. The concept that this illustrates is how prevalent presenteeism in healthcare workers, how up until COVID, and still during COVID, we go to work perhaps when we shouldn't be there. We sacrifice ourselves to others, but presenteeism, often if we're not feeling well, we can be there in body, but not necessarily in spirit. But it's really hard not to go to work. I've got a colleague that is an anaesthetist who had a sore throat, and they felt that they really needed to do the right thing, obviously, went and got the COVID testing. But then I spent about half an hour or so on the phone with her yesterday, talking about how guilty she felt, and why did she feel a sense of shame in letting her colleagues down, not turning up at work that day while she was waiting for the COVID tests. Next slide. I'm talking too much. This one's about self-care, and it's about exercising and eating right and spending time that you loved and doing whatever soothes you. And I actually did love the message in this, that it's perfectly okay to give yourself permission to lounge around in your pajamas all weekend if you want to. Next slide. I can come back to mindfulness at the end if we need to, so I want to go on to the next slide. But I will talk a little bit about this one, because in the time of the pandemic, there isn't actually much that many of us can do to change the overall thing, the overall scheme of things. And we just have to go through it and do what we're told and follow the motions. And it's all we can do sometimes is accept that there isn't much we can do, that we've got to let this thing play out. We've got to leave it to others. And all we can control is how we let go of that personal control and think of the collective issues. The next one. Won't dwell on this one too much. I've talked a little bit earlier about how it's all an emotional roller coaster. But sometimes when life feels really chaotic, getting back to the simple stuff. And when you can't control the big picture, you can control how well the laundry's folded, and you can get a certain amount of satisfaction. Well, I can anyway, from thinking I've got the healthiest pot plants I've ever had at home. They haven't died on me because it's a pandemic. Next slide. And this is a conversation I've had with many of the doctors and nurses I've seen at the moment. It's COVID. Life isn't the way it was meant to be at the moment. And it's that really hard bit of trying to find some joy in the situation as it is now. And the next one. This I love, because I think as doctors and nurses and all healthcare workers, we can at times be a bit renowned or a bit shamed at times for having such a black sense of humour. But we know in the tough times, humour gets us through. And from a sort of psychological point of view, from a psychodynamic perspective, humour is a very healthy, it's a mature defence mechanism. It's okay to use humour as a way to get through. You need to have a few other mechanisms as well. But I liked Snoopy saying, every time you find some humour in a difficult situation, you win. But I also include this because having a sense of humour or losing your sense of humour, I think, is a very sensitive indicator that you're getting into strife, that you're beginning to burn out, or that maybe this is depression creeping in. That if you find you're not laughing at the things that you used to laugh at, or you can't find the humour in it, or your humour's become much more cynical, then a few red flags need to go up. And the next slide, and I'm on a bit of theme of dogs here. If this is where, if I was giving a talk, I'd to an audience that was in the room, I'd be going, who's got a dog? Who talks to their dog? Whose dog listens? Whose dog understands? Well, my dog does all of those, but this isn't my dog, this is somebody else's dog. But poor Ginger here has been listening to her owner droning on for many, many hours. And Ginger realised that she wasn't actually cut out to be an emotional support dog after all. If your dog's had enough, and I'm trying to use this metaphorically, obviously, it's time to move on to the next slide. And thinking about what your support mechanisms are. I can't list every support mechanism here, and there are going to be many that I have, but I've just included a few. And obviously, our really important supports are our family and our friends, but I've just put a few of the more professional ones here. And think of your support systems here from an emotional point of view as being very layered, from peer support amongst your colleagues, from mentoring, somebody more senior who can help you through, from supervision, somebody who can help you do or deal with the clinical work or the whatever work you're involved in at this time. And then all those are preclinical interventions. And then think if actually you're getting a bit more worried about your psychological health, seeking some clinical help from your GP, from organisations like the Victorian Doctors' Health Programme or the Nurses and Midwives Programme, whether you need to see a psychologist or whether you need to see a psychiatrist, different layers and staged approaches to getting and accessing and thinking about the supports available. And obviously I haven't included things like EAPs, employee assistance programs and other supports here. It's not meant to be an all-inclusive list. But if we go on to the next slide, I've just put up here 3 of the organisations I'm involved with at the moment. Hand in Hand is an amazing initiative that was the brainchild of Tani Bridson, who is a stage 1 psychiatry trainee up in Queensland. And this is peer support for all healthcare workers, and it's all across the country. And both Brett and I are involved in that heavily, and we can talk more about that if people are interested. I've put up here the Pandemic Kindness Movement, which is at the moment an online resource, which links in to multiple other resources that are in a sort of, again, a tiered way, which is like this Maslow's hierarchy you've got on the right-hand side of the screen. And then I've just put the Victorian Doctors' Health Programme up on the screen as well. And as Richard said, I was the medical director there for many, many years, and I'm just back at the moment helping out to help the organisation get through the pandemic and move on. So next slide. And I just want to share a few thoughts with you that with all that we're experiencing in the pandemic, we have to be very mindful that a lot of it is understandable responses and reactions and experiences to extremely abnormal circumstances. And we have to be aware that we're not pathologizing things that are understandable experiences. Feeling horrible feelings at the moment doesn't actually mean that you've got an illness, but we don't want to miss illness. So we've got to keep alert like that. And the other important thought is, it's really important to be aware of where the supports are. And if you're not going to need them for yourself, you might need them for other people. And you need to know about the supports before you need them. There is nothing worse than having a really severe toothache and not knowing who your dentist is. Next slide, which I think is my last one, and then we'll move on to questions. So next slide, Brett. I tried to leave us with a few positive thoughts about COVID, and what I tried to think up a few positive COVID side effects. Come across a lot of people and in the time of COVID, and a lot of new connections and new colleagues and new friends on Facebook. I think that's a positive. Many of us have had to upskill in a lot of ways and find new ways of doing things, and found that we can actually do it. We can actually speak on Zoom, and we can control sharing screens and things like that. We've all had to be more flexible. And some of us have had more time with our families. And then I thought I'll put a plus and a minus on that, because that's got the goods and the bads about it. But we've all had to learn new coping strategies. But one of the things that I think is really coming out of COVID is that it is actually easier psychologically, and it is less stigmatizing to seek help now we've got COVID. And when we're seeking help at the time of COVID, there's people coming forward seeking help for many, many non-COVID issues. It's just that I think that because of the pandemic, it's made it more okay to reach out and seek help, even if it's a non-COVID related issue. So that was all I was going to do in my bit of the presentation. And I'm sorry I've not left us much time for questions.
Well, listen, Kim, thank you ever so much for that. And thank you again, Brett, as well, for two great presentations. I think it is important that we have some conversation now, though, and there's three questions have been posted up. And all of them, I think, relate to how we can cope from now on in one way or another. One of them is a really outstanding point, I think, which is for those of us who felt vulnerable during the last outbreak at Peninsula Health, is that what could we do to prepare and feel able to participate in work if there's another outbreak here, or if there's a third wave. So I think, can I ask you both, and we've only got 10 minutes, and we've got 3 questions, so maybe 3 minutes per question.
So I might give Kim a rest and just take off first. I think that what a lot of people don't realise is they were wonderful copers for 30 or 40 years. And one of the things that happens after an extremely traumatic event is people lose their innate coping. They forget their innate coping. They stop doing things that, and of course you mightn't have actually conceptualized it as a coping mechanism. You might have called it book club. You might have called it, you know, conversing with friends. You might have called it exercise, but these are actually fundamental coping. So the first thing that I would do is I would do a little audit of what you were like before, what things brought you joy, what things made you cope, what things helped you get through the day, and make sure you're doing it. I have a very old prescription pad, and sometimes I write this little prescription for myself. It goes, read science fiction rubbish, nocte, because of course my life's full of, you know, psychiatrist life's full of drama. I don't need to read serious literature. I can read non-serious literature. And this is a coping mechanism. It gives me an hour a day to cope. So the first thing I would do is do an audit of what your innate coping was, and to make sure you fairly religiously prescribe that back to yourself. And you might have to do it creatively in lockdown, but that's something that you should think seriously about doing.
Thanks, Brett. Anything to add, Kim? Or
Oh, agree with every word Brett said, of course. I'll just go back to one of my last slides as well. You don't need to show the slide thing, but I'd make sure that you're got your own list of resources and places that you could turn to if you felt you weren't coping. Make sure that that's sort of secured and shored up. make sure you do know who your GP is and that you do have the relevant telephone numbers of people to ring, and you've established those connections probably before you need them. I think really important to connect with whatever's meaningful to you if we go through another third wave. And I love Brett's bit about reading science fiction. For me, this is not because it's meaningful, but for me, one of my best remedies is just pure escapism. And I get the feeling every so often that I need to watch the Blues Brothers movies. So I watch it because I know when I'm watching that, I am nowhere else except in that movie. And a bit of healthy escapism is, I think, got a lot going for it.
So it's great to see you back at VDHP putting the band back together, Kim.
Oh, don't.
Now, I'm so aware of time ticking away from us. Amanda Armstrong has asked a question that you could do a whole session on, which is, how can we help healthcare workers feel comfortable receiving care themselves? 1 minute.
Oh, can I vote for the whole session? That is a really tough one, and absolutely too tough, because we go into healthcare because we want to give to others, and then that gets further and further conditioned into us through any training that we get. I think it needs a whole workshop.
Could I offer a little insight that I think this is all about discrimination? I think this is about brainism. Okay, so for instance, you're entitled to go away, go along and see a cardiologist and look after your heart. You're entitled to go and look after your gut. Some people are interested in looking after even other interesting places of their body. I think it's discrimination not to go and look after your brain. It is the most complicated organism. It is the most important organism. And we should be overwhelmingly more at ease with the fact that it can be, running on less than optimal, circumstances. And there's wonderful people out there that will help you with your brain. So I think it's stigma, but I think it's discrimination against brains, folks. We should think about that. Okay.
Now, I'm going to roll up 3 or 4 questions into one for you, because I actually think it's they have a theme. And this is regarding what can we as an organisation do to invest in programmes to help our staff to mitigate the risk that you've been talking about of this kind of slow burn trauma that we're all experiencing. And in particular, keeping an eye on the time axis, because what we know and what you've demonstrated, Brett, is that the time axis is critically important. And it's actually going to be the next couple of years that we as an organisation need to be thinking about what we can do to support each other systemically and personally.
I think that there's some wonderful old animal psychology, which is still very, very good research, that uncertainty is the most stressful, variable that someone can have. And if you have a poor little rat and if you shock it regularly, they actually don't get very stressed. But if you do it irregularly in an uncertain way, they get incredibly stressful. So uncertainty is not your friend from an organizational psychology point of view. And the way to decrease uncertainty is 2 things. One thing is really, really good communication, and there probably can't be enough of it. And the other thing is something that Kim said. I can be really very certain that there will be uncertainty, and we need to embrace it. We need to embrace the fact that there are things we don't know, and we're just going to have to help each other live with that. I don't know if there's going to be a 3rd wave. I have a son in Melbourne, and I would love to see him, and he's in lockdown. I have a daughter in London, by the way. I'd love to see her, and she's in lockdown. But I can tell you with certainty that it's uncertain when I will. And we just need to learn to live with that organisationally and personally. So there's the 2 things I would advocate for, well, actually 3 things: communication, accepting uncertainty and having a very long framework, having a 2 to 3 to 4 year framework that involves both work and issues outside of work, like financial stress amongst colleagues and friends.
Thanks very much.
The only thing I'd add to that is, I think from an organisational level is building in additional avenues to connect with our colleagues and to really build the connections. And I think it's with the uncertainty, it's the side effects of those connections. The side effect of the team meeting that's meant to discuss something is actually the team coming together, and it's that positive side effect that we're looking for here. And it's just built more and more communication and more connections.
So Richard mentioned, actually, I can't remember who it mentioned, but Richard mentioned that Kim and I have been doing a lot of these webinars. We were talking a lot to anaesthetists, actually, and it's really clear to me, this is following up Kim's point, that a lot of the peer support of some medical groups is in the tea room. And as Kim just said, we've lost that communication. We've lost the conviviality, the support of the tea room. And if organisations can do creative ways to recreate that, that would be really positive.
Thanks, Brett. I'm going to use those answers, because some of the things you've both spoken about are connection and communication. And I just want to thank you both for your presentation personally, but actually introduce Felicity Top, our CEO, who in fact I think has led the way in communicating and keeping our service feeling connected during this pandemic. So thank you both. I'll mute myself and pass you over to Felicity, who I think is on mute.
So Felicity,
we have some technical issues from...
Felicity, I can hear you a little bit, so I don't think you're on mute. I can hear you a little bit. Maybe it's a volume issue. I can hear you a little bit.
Now you're on mute.
Now you're on mute. Now I can't hear you at all.
What about now?
Yes.
Brilliant.
Right. Oh, technology. Thank you, Richard. Sincere gratitude to Brett and Kim for giving their time up today to present to us. I'm sure everybody will agree that your presentations and insights will have resonated with our teams today. I have been saying for some months now, what we have experienced and the whole pandemic is not normal. You know, it is not a normal experience. Not being able to jump into tea rooms and get that support from each other, not being able to get that friendly hug when things haven't been going so well in the day, not being able to see your mum or your kids. It's not normal. So it's important that we recognise that as an organisation, which I think we have done well. I think we are trying to support our teams. But I think we do need to understand that we need to look out for each other, and we need to use the supports that we have got here in the organisation. We are here for everybody. I think sometimes might think that we're not, but we do have some really good supports here, and we really do want to help our teams work through the experiences that they've had over the last months. I really like your term, Kim, post-traumatic growth. I love that. I think we will be a better and stronger organisation from what we have gone through. I think we'll take the lessons learned and be ready for that wave 3. I kind of hope it doesn't come, but I think we will certainly learn from this experience and ensure that we've got those systems and processes in place so we are ready. I think the sunshine helps. I think the fact that the days are going to get longer. I don't think we can underestimate the the fresh air. And I think you're right that we do need to really concentrate on what makes us feel good, and to use those mechanisms or those supports around us. We've got time to take some leave, and as an organisation, we've had people working for months and months and months, 7 days a week, for many weeks. Can I please ask people to try and get some time off, especially now that the days are getting longer, and hopefully soon we'll be able to spend a little bit more time outside and in the park, and you know, perhaps even in a few weeks be able to catch up with people we haven't seen for a long time. So thank you very much. I really appreciate your time with us today, and I'm sure everybody else in the organisation has. And we'll see you soon. And thanks for everybody who participated. Thanks, Richard. Okay, see you later.